Hello everyone, good evening. Welcome to today's class. Continuing with our super speciality series. Today you'll be covering a very high topic, that is surgeries in head and neck. So let's try to cover as many important topics as possible. I hope you guys can see me and hear me clearly. Please respond in the YouTube chat box while you guys are joining in. Okay, it will be an MCQ pattern class. Each topic we will try to dissect a little bit in detail to get the important pointers. So don't just look at the MCQ, look at the theory of the topics also. That is my message for today. Alright, so please message in the chat box so I know you guys are online. Great. Okay, so as people are joining in, let me tell you about today's class and let me tell you about myself. We on the Unacademy NEET PG platform help you prepare for your NEET PG exam. Apart from other competitive exams, I am Dr. Amrit Nasta. I am a bariatric surgeon from Mumbai and I am your surgery educator on the Unacademy platform. You can follow me by downloading the Unacademy learning app, where you will find a lot of educators like me covering different subjects for your entrance exam preparations. A lot of batch courses have started in March. Okay, so a lot of batch courses have started in March on the Plus platform covering different exams. So there is a rapid revision batch course. There are long-term batch courses which will help you for exams next year, and so on. So a lot of things are happening. You can see the slide, you can go on the platform and you can get the details of all these courses. Remember, if you wish to subscribe, to use my referral code, that is 10 surgery. This code will get you a 10% discount in whatever subscription plan you choose. Also, there are a lot of free classes happening, like I am conducting a lot of YouTube sessions, a lot of special classes which are free you can attend, as well as a lot of tests and test series happening on the platform. These can be accessed from the app. You can see the different dates where different tests are there. So the important ones are the grand test series that I want you to really focus on. So every week there is going to be a grand test which will give you like a mock preparation for your entrance exam. These are absolutely free of charge, so you should definitely attend them. And you will get an idea of where your preparation is and what ranking you are having. So there are two kinds of subscription. There is a plus subscription and an iconic subscription. Plus subscription, you have live classes like we are having now, but with a smaller audience, so you get better interaction. You have batch courses like I was telling you about, or you can take the iconic subscription. Iconic has plus as well as recorded lectures, video lectures, handwritten notes of prep ladder. That is like a double subscription in one. So you get double benefits. So iconic subscription plans are only 1 year and longer, so they will help you if you are appearing for exams next year. If you are giving exams this year, then a plus subscription should be enough. Then you should take a shorter subscription depending on when your exam is. Okay, so 1 month, 3 months, 6 months, जो भी आपकी exam हो उस हिसाब से go for a subscription plan. A lot of educators like me will teach you subjects comprehensively. This is the referral code you should use. This code will get you a 10% discount in whichever plan you take. Okay, so some new things happening, like the new batch courses which you need to know about, a lot of test series going on, grand tests going on. So you can get more details on the app or on the website, which you need to be a little bit aware of. Those are the free things which you should definitely take the advantage of. Okay, so with that in mind, let's begin today's class. It's a very high topic. There are many small topics in head and neck surgery. Some I have covered before, so I won't be delving too much into them in detail. Some new ones, some questions that I got from other clinical books, shorts, pre-test, those are the ones I will share. And the important one-liners. Now even the one-liners are going to come in clinical form, as I will show you. Okay, but basic knowledge has to be there, so please do not be under the impression that one-liners won't come. They will come, but they will have a little length to the question. That is the only different thing. So your knowledge has to be beyond clinical. You need clinical as well as basic information of everything. So at least in surgery, let that be my responsibility and make your life easy. Okay, new question. This is from Schwartz pretest. Okay, this is not created by me. This is there in Schwartz pretest. The kind of question you should expect. So a young woman has a midline neck swelling. It moves up on swallowing. You make the clinical diagnosis of duct cyst. Which of these is the most appropriate management? Interesting, eh? Which of these is the most appropriate management? Let me tell you, when I saw this question, it took me a few seconds to get to the answer myself. मैं भी थोड़ा ऑप्शन देके कंफ्यूज हो गया. I got this question today only. This you will not see in any of my previous YouTube or special classes. Even though thyroid I have discussed थोड़ा बहुत. Yeah. Let's see what Datesh and Kaustubh and Thanu and all have to say. Interesting question. See, you hunt and so many things can be made. You just have to hunt. Kaustubh says C. Okay. Very good. I'll tell you what answer is given in the book and what is the reason for that. Yes, anyone else? I can give you one more option, option E, and that is incision and drainage of the cyst. And if I want to spice things up a little bit more, I will give you an option F, surveillance. Okay. Now you can think. एक question के 6 option. Just to spice things up, I put the other options. Because you need to think. If they want you to be having an approach of clinical questions, these are the kind of clinical questions they will ask you. Okay. Very good. In pre-test, the E option was, I'll tell you what is the E option given in the book. Same as D, but instead of sampling of central cervical nodes, वहाँ पर option था thyroid gland biopsy, means biopsy of the thyroid. That was the E option. I didn't put it. I said, anyways, your life is so difficult. Let's not make your life more difficult than it already is. So I was kind enough to not put the E option. Because at least my students should know कि thyroid की तो biopsy करते नहीं. Barring one or two scenarios, in thyroid you don't do biopsy. You do FNAC. Okay, very good. So I got B, C and D. Nobody went for A. I've put two more options. You can choose any of those also. Anyone for E or F? Correct? एग्जाम में EF नहीं आएगा. एग्जाम में 4 ही ऑप्शन आएंगे. Don't worry. Okay, fine. So first things first, this is a thyroglossal cyst. They have been kind enough to tell you what it is. Instead of this, they could have said swelling. Instead of giving you the diagnosis, they could have said swelling moves up on tongue protrusion. It means it's a thyroglossal cyst. That is the other differential. Other clinical finding. So they are asking you the treatment of thyroglossal cyst. सिर्फ excision has a problem. What is the problem if I only excise the cyst like a sebaceous cyst? सिर्फ excise करूँगा तो क्या होगा? What's the problem in excision? Deependra says A. Very good. So is there any problem with only excising the cyst? Because it's a duct cyst. Excise the cyst. Okay. So if I excise, absolutely right, there will be a very high risk of recurrence. You have to understand the pathology to understand what is going to be the treatment. So excision won't be the answer. Lymph node sampling, of course, is not required. You don't need. It's a benign condition. Incision and drainage, why I should not do? If I do IND of the cyst, is it a problem? Incision and drainage. Please remember, I'll give you a dictum in surgery. There is no cyst in surgery. No cyst. The treatment of which is IND. Okay, please. कोई भी cyst का treatment IND नहीं है. If there is a cyst, it will have a cyst wall. If you want to prevent recurrence, you have to excise the cyst wall. The wall is a secretory layer. If the wall remains, the cyst will come back. So either you excise the wall or you marsupialize. I am giving you a dictum in surgery. कोई भी cyst का treatment, full blown treatment will never be IND. Is there any scenario where a cyst will be treated by incision and drainage? at least initially. Is there any cyst or any scenario? Let's say I have a thyroglossal cyst or a branchial cyst or a sebaceous cyst, and I tell you my first step of treatment should be IND. When will that be? I'll say forget the cyst wall, remove that later. Superficially located, no, superficially, all most cysts are superficially. Absolutely right, Deepthi Sharma. Excellent answer. If the cyst is infected, if it's an infected cyst, infected sebaceous cyst, thyroglossal cyst, you may initially do this and then do the cystectomy. Okay, so simply put, incision and drainage is the treatment only of abscesses. सिर्फ abscess and not all abscess. Some abscesses are treated by incision and drainage, not all abscesses. Some abscesses require more. Alright, coming to our question. So obviously 3 options you have eliminated. So IND is also gone. Now you're left with excision with central hyoid excision, excision of central hyoid, and tract till the base of the tongue. On surveillance, I am giving you a second chance. You can opt for surveillance also. Now you have only 3 choices: B, C, and F. You can still think about surveillance. What is a thyroglossal cyst? Understand, this is the tongue. Base of the tongue, there is foramen cecum, from where a duct is formed. This duct is the thyroglossal duct. Thyroglossal duct, which goes down in the neck. Okay, now imagine it's going in the neck. It is partitioning, giving you lobes of the thyroid. Can't wait for surveillance because it can compress other structures. When it compresses, that time you do ना. अभी तो compress नहीं कर रहा. जब करेगा तब देखेंगे. Correct. Anyways, so this is how the thyroid is formed. Now in some people, some part of the thyroglossal duct remains. It remains. It does not degenerate. In most people, most of the tract degenerates. In most people. In some people, some part of the tract remains. Okay. The part which remains is secretory, so it will form a thyroglossal duct cyst. बाकी सारा tract है. What is the most common location? What is the most common location of thyroglossal duct cysts? Yeah, most common location. If you understand the fundamentals, you'll never have a problem. Subhyoid, absolutely right. Subhyoid, ये तुम 3 लोगों ने बोला है, 2 लोगों ने. Subhyoid, infrahyoid, एक ही बात है. So somewhere here is the hyoid bone. The tract goes through the hyoid bone. Okay, the tract goes through the hyoid bone, and the cyst is going to be subhyoid. बाकी सारा tract गया. Is there any complication associated with thyroglossal cyst? It's a neck swelling. It will grow. Any complication can happen because of the cyst. Fistula, okay, it can get infected. It can rupture. It can form a fistula. Any other? Which malignancy? Which malignancy? Yes, which malignancy? सिर्फ कैंसर नहीं चलेगा मेरी क्लास में. You have enough knowledge. Datesh, Pravesh, Kaustubh, you have been attending my classes regularly. I need precise answer. Which malignancy? Very good. Papillary CA. Rare but possible. Which means if it is presenting, if the person has a lump with which she is presenting, you cannot do surveillance. Because the person knows it will get complicated, surgeon knows it can get complicated, you will not leave it as is. There is a good chance of it getting complicated. So surveillance is not the treatment. Now the choice really is between these two. Okay, the clinical sign I already told you, important clinical sign, it moves up on deglutition, moves up on tongue protrusion. You know why? Because the tract is attached to the base of the tongue. So when the tongue is protruded forward, it will pull the cyst up. So the cyst will go up as he puts the tongue forward. How do you confirm? Investigation of choice. Investigation of choice. Neck swelling. How do you confirm that this is a thyroglossal duct cyst? Yeah. Arey? Clinical question. Investigation of choice. Investigation of choice of thyroid swellings. Chalo. Let's make it simple. Investigation of choice of all thyroid swellings. USG will show a cyst. How do you know it is thyroglossal cyst? It is USG guided FNAC. Answer is FNAC. It will show the epithelial lining of the cyst. What is the pathology of this cyst? What pathological type of cyst is this? Is it a sequestration cyst? Is it an implantation cyst? Is it a retention cyst? Is it an extravasation cyst? What type of cyst is this? Is it an embryological cyst? Is it like a dermoid cyst? What type of cyst is this pathologically? ये आपको pathology में पढ़ाया होगा, I'm sure. This is, you are not learning this from me. अरे secretory epithelium कि अगर entry और exit drained है, congenital is not a pathological type. It's not there since birth. Okay, it's not there since birth. This is a type of retention cyst. Okay, it's a type of retention cyst. Last part is treatment. Now you know it has to be treated. For one thing is clear, it has to be treated. What do? You said don't excise only the cyst. Then what else do you excise? What is the name of the procedure for thyroglossal cyst? Name of the procedure? If you only knew the name of the procedure, you would have known the answer. Yes, Dipendra Datesh, cyst trunk, very good. What do you do in cyst trunk? See, सब answer तुम लोग दे रहे हो. What do you do in cyst trunk? You remove the cyst. You remove the tract and you core out a part of hyoid bone. So cyst plus tract up to hyoid with core of hyoid. Okay, you remove a core of the hyoid bone surrounding the tract. Do you have to remove the tract above the hyoid? Do you have to remove the tract above the hyoid? ये तो question में है. Central portion and the tract to the base of the tongue. Question में थोड़ा time कम नहीं कम कहाँ है? 1 minute you will get to solve the question. 200 questions, 210 minutes. आराम से you will get. Yeah. Do you remove the tract beyond the hyoid or you only go till the hyoid? According to cyst trunk. So, and the tract to the base of the tongue you don't have to remove. You only remove till the hyoid. ऊपर जाने की जरूरत नहीं पड़ती most of the times. So at least cyst trunk ने ऐसा नहीं बोला. ऐसा क्यों? Why I don't have to remove this part? Why I don't have to remove this part? Why I only go to the hyoid and not beyond it? Most of the times. Yes, you will only tell the answer. Answer is kind of written. Answer is kind of written. Why I don't have to go above the hyoid bone? It's because the most common location is subhyoid. The retention, the persistence is never above the hyoid. If it is above the hyoid, the swelling will be above the hyoid. If the swelling is above the hyoid, obviously you'll remove the cyst above the hyoid. So most of the times, because this tract is fibrous, you don't have to remove it. नीचे का you have to remove because नीचे you don't know how high the tract goes. Definitely you know hyoid के नीचे तक है. So hyoid तक सब निकालना है. That is the message you need to take about this question. Okay, are we very clear? Absolutely clear. All possible points covered on this. Okay, let's move on. Okay, this is again from Schwartz pretest. Schwartz pretest. It's a very nice question. So there is a elderly male, a small mass in the right side of the neck. He says it has been slowly growing with pain, with so not associated with pain, no discharge. He has an otherwise negative review. On examination, it is hard mobile along the mid portion of the right SCM. What is the most appropriate initial step in the workup? Absolutely classical question. Absolutely classical. What is the most appropriate initial step in the workup? Now you have to think. You have to think like a clinician. That's what they want you to do. You have a 60-year-old person who has a mass, Mayuresh, aberrant, what you are saying, please think about the location of that aberrant, lateral aberrant thyroid. वो कहाँ होता है वो सोचना जरा सोचना. And see where this mass is, mid portion of the SCM. So I hope you are not mistaking something. Don't do such clinical lafde. So there is a mass on the anterior border of SCM, middle part, 2 centimeters, in an elderly male. What will you think? What will you do? You give him antibiotics, FNAC, excision, MRI neck. And I will change this question, my scenario. Tell me, I'm telling you, I will change a few words and then the whole thing changes. All of you are saying FNAC. Why is that? Why FNAC? You are saying it is a lymph node. Yeah, it is a lymph node, but it's a 2 centimeter node, incidentally diagnosed, small mass, on an annual examination. He does not have any complaints. Okay, there are no complaints, no pain main kuch nahi hai usko. If you check your neck, you may be having a lymph node. If you check properly. हम कितने लोगों को नेक नोड्स होते हैं? हम सब थोड़ी एफएनएसी कराते बैठेंगे या एक्सेशन कराएंगे. कब कराएंगे? It is fixed to SCM. No, excuse me, mobile. Hello, my friend. Mobile. Mayuresh, you are not reading the question properly, huh? Don't do that. Don't do that. It is saying mobile 2 centimeters. Could be metastasis. Why would you think it is metastasis? Metastasis from where? Oral malignancy. Oral malignancy is what? Yes, this is a lymph node. What is the level? Anybody? What is the level of this lymph node? Neck node level. What level of neck node is this? Mid portion of right SCM is what level? Yes, very good. Yes, Datesh, don't be so quiet today. Don't do this to me. Level 3, thank you. No, Mahak, it's not level 2, it is level 3. Mid portion of SCM is level 3. 1A, 1B is submandibular. 2, 3, 4, upper, middle, lower. Deep cervical. So this is probably middle deep cervical. Probably. Oral malignancies go to middle deep cervical? Normally no. Normally 1A, 1B normally. Anyways, coming back. This is a lymph node level 3. It is hard. Hard. Important. It is hard. So though it is mobile, painless, it is hard. This is a dangerous sign. There is one more dangerous sign. Anybody can tell me in this patient pertaining to the swelling. There is one more dangerous sign. Because it's a dangerous sign, this has to be investigated. I cannot give antibiotics. Okay, I cannot give antibiotics. This has to be investigated. MRI neck is to stage. Age. Okay, if the patient was 38 years old. Same scenario. There is one more dangerous sign. MRI neck is to stage. It cannot be the initial step. Please remember, MRI is not going to diagnose. Diagnosis requires tissue. Slow growing is dangerous. I thought that was good if it's slow growing. I'll tell you what the dangerous sign is. Anybody can tell me, then I'll give you the answer. Excision biopsy कोई diagnostically नहीं करता. Answer is FNAC. Most of you are correct. Thinking is correct. What is significant lymphadenopathy? Anybody knows this? Significant lymphadenopathy. Which lymph nodes are considered to be significant? Acha, so painless is worse than painful. Is that what you're saying? So if I have a painful node, it's a bad thing. नहीं ऐसा नहीं है. Anybody knows what is significant lymphadenopathy? Significant means warrants further investigation. This you will get only in clinical books. This you will not get in MCQ books. This you will not get in theory books. Textbooks में नहीं होता है. Significant lymphadenopathy. Okay, Mehak, you're partly right. Partly right. So there is a criteria. If someone has an inguinal node more than 2 centimeters, or cervical node or neck node more than 1 centimeter, or any axillary of any size does not matter, or any node which is tender, hard, fixed, or matted. Any of this significant warrants further investigation. These kind of nodes you will not give antibiotics and tell the patient, okay, if the node goes you are fine. They warrant investigation. This is the meaning of significant lymphadenopathy. Please remember this criteria absolutely correctly. So in this case, this is a hard node. एक hard sign मिल गई. It is more than 1 centimeter. Cervical more than 1 centimeter. Another dangerous sign. These warrant investigation FNAC. Age, okay, fine. If the same node was not hard, if the same node was firm, if the same node was 1 centimeter, in that case, answer would have been antibiotics. Okay, in that case, answer would have been antibiotics. If the same node, same scenario, patient gives this history, he had a neck swelling, which is now started giving some purulent discharge. Why even tender? Tender means there is a clinically significant infection. That's why it is tender. Means it is not there by some small problem. Only a big problem will cause the node to become tender. Yes, tender usually means benign, but we are not worried about benign or malignant. We are worried about significant pathology, something that warrants further investigation. So if this node ruptured and had a purulent discharge, then what would be the answer? Purulent discharge, painless node along the SCM, which has now started giving discharge. Purulent discharge. And no inflammatory signs. It's painless. Then what will be the answer? What am I talking about in this case? What is the pathology? Same 50-year-old male, neck mass for a few months. It has started discharging now. Patient also, and it was non-inflammatory. Patient also says loss of weight. Now what will you think? Cold abscess, absolutely right. Cold abscess. So what will be your treatment? Or what will be the most appropriate initial step in the workup? Yeah. See, I told you, few words you change, answer changes. And I'll remove this FNAC. Okay, I'll give you one option of pus culture sensitivity. Now tell me what is your answer. 2 weeks of antibiotics, pus culture, excision biopsy or MRI net. ऐसे ही सोचना है. These kind of things you can only answer if your concepts are absolutely clear. They will not ask you what is cold abscess. They will give you a scenario and they will tell you what is the next step. Yes, no answers. So many people online not giving an answer. Answer there would be excision biopsy. Please understand, this probably no inflammation, cold abscess means probably tubercular lymphadenitis. Pus in TB is not going to show the organism. Don't culture it. Very difficult to show culture. Very difficult. Best thing, get the whole node out, and send it for histopathology, and you can send it for cell culture, जो टीवी में करते हैं, which is called बैकटेक, और यू कैन डू जीन एक्सपोर्ट. ये सब आपको मेडिसिन में पढ़ाया होगा, जीन एक्सपोर्ट. You need more specific testing. You can't just send it for culture. It will not grow on your blood agar and all. TB is not going to grow, right? So simple question, how things can change. Significant lymphadenopathy important. Take this from me today. Okay. Now some basic level questions where you cannot make any mistakes. So this skin disease affects white skinned people exclusively, and when you take a biopsy it shows palisading arrangement of cells. Palisading arrangement. Again, this is a new question, but this I have made from Bailey. This is not from pre-test. This is from Bailey. The points are from Bailey. Yeah, exclusively affects white-skinned people. And then I will ask you some disease which is more common in black-skinned people. वो भी सोच के रखना. That is my next question. Tatish says basal cell carcinoma. Acha. So this disease affects white-skinned people exclusively, and then you also think of a disease which is more common, not most common, more common in black-skinned people. It's not a malignancy. Yeah? This question is not about malignancy. Okay. So very good, Datish, Hanu, Kennedy. Correct answer, basal cell carcinoma. Absolutely right. The key is peripheral palisading of cells. The cells have a typical arrangement. I will show you. Now give me the answer of this. Which dermatological disease is more common in black-skinned people? Don't say acral lentigerous melanoma. Tell me a benign disease. Or don't give me high funda dermatological diseases. Something that is faced by surgeons. A surgical disease. More common in black-skinned people. More commonly seen on the trunk. Yeah. Anybody? Starts with a K. On a particular triangle on the trunk. Very good. Yes. Answer is keloid. Absolutely right. MM. You're right. Medical marvel. The answer is keloid. So these are the kind of things you need to be aware of. Now, I'm telling you absolutely important points how they will give you a case of basal cell carcinoma. They will give you a picture of a person who has a lesion near the eye, inner canthus of the eye. It will look nothing. Okay, it will look nothing like a tumor. You'll see some patches. It appears clinically variegated. Okay, it has a variegated appearance near the eye. You get a picture of something near the eye, go for BCC. It is always seen on the face, sun exposed areas. And then they will tell you biopsy was done. They may give you a biopsy picture like this. This is what you need to see, how the cells are arranged in a certain pattern at the edge. This is called peripheral palisading. Peripheral palisading. From what layer of the epidermis do you get basal cell carcinoma? Basal cell carcinoma, 80% of all skin tumors. 80%. SCC, melanomas, 20%. Basal cell carcinoma, 80%. That's how common it is. I have seen quite a few in my life. I have seen one very classical near the eye also. I remember that lady so clearly. Absolutely clearly, and what we had done. Yeah. So, it shows peripheral palisading. Absolutely right, it arises from the basal layer. A squamous cell carcinoma arises from which layer? Squamous cell carcinoma. I hope someone has taken dermatology for you. Squamous cell carcinoma arises from which layer? Usually. Answer is not basal layer, so don't say the same thing again. Basal layer से basal cell carcinoma आता. Squamous cell comes from which layer? अरे 5 ही तो लेयर है डर्मिस एपिडर्मिस में, वही ऑप्शन में होंगे. अरे S for squamous, S for stratum, spinosum. So it comes from the spinous layer. Okay, S for squamous, S for spinosum, basal, basal. Of course, it goes together. No doubt about it. Uh, what is the treatment? Treatment of choice rather of a basal cell carcinoma near the eye. वो लाइन पे होता है ना जो नाक से कान पे जाती है नाक से नो माउथ से कान पे जाती है उसके ऊपर along that line usually near the inner canthus of the eye. Treatment of choice of VCC. You want options for this? I'll give you options, but I think this you can answer without options. Local application of imaquinone, Mohs procedure, wide local excision with 1 centimeter margin, wide local excision with 2 centimeter margin. चलो दे दिए चार ऑप्शन. Local imaquinone, Mohs procedure. I hope you know what is Mohs procedure. WLE with 1 centimeter margin, WLE with 2 centimeter margin. Okay, understand this is on the face. On the face, if possible, do not do a wide excision. Okay, because you do a wide excision on the face, it will be a very big defect. You'll need a big plastic reconstruction. Cosmesis will be gone. Ideal treatment, yes, all of you are correct, is going to be Mohs procedure. Mohs micrographic excision. Ideally, understand these things. You don't have to mark. Squamous cell carcinoma, if it's on the face, you can do a Mohs procedure. But squamous cell carcinoma can happen anywhere. Penis, oral cavity, correct? Anywhere on the trunk, anywhere on the limbs. So there you don't need to do a Mohs procedure. There you will do a wide excision with 1 centimeter margin. But yes, face, where normally you get basal cell carcinoma, Mohs procedure is the treatment because of cosmesis. So the patient that I had seen in my life on the face, we did not do a Mohs procedure. We did a wide excision with a flap, local flap, advancement flap. I'm just telling you, but ideally it should be Mohs procedure. Okay, important question. These are the kind of topics which we normally don't study in our MBBS. You know, these ekdam head and neck is absolutely ignored. I am not going to ask too much of parotid because I'm sure you will know parotid more than me. I'm going to ask the peripheral head and neck topics जो हम normally करते नहीं. We need abdominal surgery and thoracic surgery. अच्छा, you can follow me Somalia Media on my Telegram ID. Then you can tell me whatever topics you want. I will share my Telegram link at the end of the class. तभी आप मुझे बताना. Whatever topics you want. Yeah. So there is a female with a neck swelling which is lateral since 1 year. This is also along the anterior border of SCM. So think about this. This is firm. This has lateral mobility. Before Mayuresh says it is not mobile fixed, this has lateral mobility. It is firm in consistency. It has transmitted pulsations. Which of these investigations are not advisable? Which of these investigations are not advisable? CT, Doppler, FNAC, angiogram. First you need to think, what is this swelling, right? क्या है क्या ये एंटीरियर बॉर्डर और SCM पे कौन सी स्वेलिंग आ गई है जो फॉर्म है कंसिस्टेंसी में. You love my lecture, please like my video if you like my lectures. ये क्या swelling है? What is this swelling with these transmitted pulsations? Excellent, I'm getting all different answers. I have gotten A, C and D. Nobody for, I have asked you which is not advisable. You want to do USG Doppler? Nobody has gone for B. What is this swelling along the anterior border of SCM which has lateral mobility but not up and down mobility with transmitted pulsations? Yes. What is this swelling? Interesting. Yeah. What is this swelling? This is a carotid body tumor. That's right. सब दोनों ने क्वेश्चन मार्क लिखा मतलब दोनों को डाउट था. This is a carotid body tumor. Absolutely right. See, I will give you a very simple funda. There are some common swellings which are along the anterior border of SCM. Okay, anterior border of SCM. SCM is sternomastoid muscle. And there are some swellings which are in the posterior triangle of the neck, anterior border of SCM or anterior triangle. One is carotid body tumor. One is cervical nodes. Of course. Any other? Anyone wants to add to this list? Common swelling along the anterior border of SCM seen in a child. Seen in the first decade of life. Carotid body tumor, middle age. Cervical node, elderly. Yeah. Which swelling is seen in a child along the anterior border of SCM? Usually a soft swelling. Branchial cyst. Excellent. Branchial cyst. Alright. So when they give you any swelling in the anterior triangle of the neck, think of these three. And then you proceed with that. Now this is classically carotid body tumor, seeing the age, seeing the transmitted pulsations. Transmitted pulsation means it is in the vicinity of an artery and it is pulsating with the arterial pulsations. What is this lateral mobility? What is that called? The swelling moves laterally but not up and down. What is that called? A carotid body tumor shows lateral mobility but not supero-inferior mobility. What is that called? Starts with an F. Whose sign? किसकी sign है? Starts with an F. Yes, Dhanu, your replies are visible. You said branchial cyst. I know. Yes, your replies are visible. Don't worry. Whose sign are they? It's called Fontaine sign. Oh, anyways, coming to the question. Carotid body tumor, what will you never do is going to be FNAC. Okay. You will never do, it will be FNAC. Now, what is this carotid body tumor? How does it look? See, this is the sternomastoid. It is along the anterior border. Over here. Anterior neck swelling. It is coming from the chemoreceptors. Okay. And typically this is the location. So this is the common carotid bifurcation like this. The tumor will be at the top of the bifurcation. Because the carotid bodies are over there. The carotid bodies are over here, so tumor will be over here. And this tumor will spread. So the arteries will go more laterally. What is that called? At the bifurcation, the arteries get splayed laterally. The internal and external carotid, they become lateralized. What is that called? And that is the diagnostic hallmark, where the tumor causes the internal and external carotid to get splayed. What is that called? Starts with an L. It's called Liar sign. Okay. And I told you about lateral mobility. That is called Fontaine sign. Liar, liar. L-Y-R-E. Just say tire, वैसे liar. So that is Liar sign and Fontaine sign. Okay. So this you will see. That's right, Dhanu, Datesh. On angiogram. Now this angiogram can be an angiogram like this. What type of angiogram is this? Is this CT angiogram, MR angiogram, DSA or Doppler? What type of angiogram is this that you see in the picture? And now it is showing you a very good appearance. This is the bifurcation. There is a tumor over here which has caused the internal and external carotid to be splayed. Absolutely right. This is a DSA. Okay. Digital subtraction angiogram. Please have a nice good look at it. This is how a DSA looks. DSA is nothing but an X-ray where I have removed the soft tissues and the bones. So all I see is the contrast. So this is a DSA, digital subtraction angiogram. In a CT angiogram, in an MR angiogram, you will see the bones, you will see the soft tissue. Doppler is not an angiogram. Doppler you see red, blue, grey image, red, blue and grey. It doesn't look like this. You know how an ultrasound looks, right? Okay. Treatment, again, Do all carotid body tumors require treatment? Do I have to treat all carotid body tumors? Yes. Do I have to treat all carotid body tumors? यहाँ मैंने लिखा है the treatment is going to be excision or en block removal. Is it required in all the cases? Yeah. Do I have to remove the carotid body tumor? Or you can leave it. Incidentally diagnosed, let it be. No. No means I don't have to remove. If it's incidental, then I leave it. That's what you are saying, Pravesh? Interesting. I will help you. Pravesh, is this tumor benign or malignant? Is this benign or malignant? Yeah. Less than 3 centimeter observation. Okay. Less than 3 centimeter means you will take measurement. Acha. So treatment depends on Shamlin classification. You don't need to know the classification. See, usually it is benign, but I am not doing FNAC, so I'm assuming it is benign, right? मैंने FNAC तो की नहीं, so I don't know whether it's benign or not. In most cases, you will have to remove, unless the patient is elderly and unfit. Elderly, unfit, small, asymptomatic, you can leave it, but practically all cases you have to treat, and the treatment is based on Shamlin. Either you excise or you do en-bloc removal. If it's very big, you may do a pre-op embolization of the tumor. You may do a pre-op embolization of the tumor. Practically in all cases you remove, and when you do this surgical excision, there is a risk of injury to a particular structure. What is that? What commonly gets injured during surgery for carotid body tumor? What is commonly injured? I'll give you a clue, it's a nerve. Anu is saying, but it can compress vagus nerve. Yes, it can compress vagus nerve. It can compress anything in the vicinity of carotid artery. What does it commonly injure? What gets commonly injured during excision of carotid body tumor? Vagus. It's not. There is a better answer than vagus. Answer is superior laryngeal nerve. Answer is superior laryngeal nerve. Okay, that is the best answer. Uh, how will you know you have injured the superior laryngeal nerve? Post-operatively. हो गई इंजर, पेशेंट को कुछ प्रॉब्लम होगा क्या? पेशेंट को कुछ प्रॉब्लम होगा क्या? The artery which is feeding the tumor. Danu is saying pre-op embolization, which artery which is feeding the tumor? Usually it will be internal carotid. But whichever is feeding, you're not going to angioembolize the whole thing. You're not going to angioembolize the common carotid artery. Yeah, how do you know you have injured the superior laryngeal nerve? What will be? Bore senses of voice, irritation to mastication. No, 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 no. Bore senses of voice. No, no. What you get? No, it's not no, no. Hoarseness. Nahi. Hoarseness is recurrent laryngeal nerve. That is recurrent laryngeal nerve that causes hoarseness. Superior laryngeal nerve does not cause hoarseness. It causes loss of pitch. Loss of pitch. It's also called loss of timbre of the voice. So he cannot raise his voice after that. आवाज की पिच कम हो जाती. This normally affects singers. Normal people को फर्क नहीं पड़ता. अगर कोई singer है तो he cannot take that up. The voice will not go up. Okay, no aspiration नहीं होता. Doesn't increase the risk of aspiration. Clinical question. Let's see what you think about this classical clinical question. Person presents with the neck swelling. Now I have come to posterior triangle. We did anterior triangle swelling. Now we are doing posterior triangle. He gives history of syncope during brushing since 1 week. All of these tests will confirm your diagnosis except. Yeah, all of these tests will confirm your diagnosis except. He has syncope during brushing his teeth since 1 week. He has a swelling in the posterior triangle of the neck. Tensor gone, yeah. That's why he cannot raise his voice. Is it Axel? Is it Alan? Is it Rules? Or is it right? Uh-huh. The test says B. Allen. You need to know some of these tests, at least the important ones. Yes, Pravesh, I am giving you some time to come up with the answer and don't listen to others. They may not know what I have asked. Yeah. So, you are right. Answer is Allen's test. What is the clinical application of Allen's test? When do I need to do the Allen's test? And what is this person having? What is this neck swelling in the posterior triangle? So, posterior triangle, there are 2-3 common swellings that we need to know. One, as is seen in this case, and second is going to be neck nodes or level 5 nodes. Okay, no problem. Neck nodes level 5, and the third will be a congenital swelling. So you need to tell me what is all this. Allen's is for collateral circulation. Fine. You are giving me an answer which you must have heard in orthopedics. Fine. It is basically okay. Thoracic outlet syndrome. Now, what is this swelling in the posterior triangle? ये swelling क्या है? In the posterior triangle. One neck swelling in posterior triangle is level 5 nodes. You know level 5 nodes. One is a congenital swelling, and one is a swelling in this case, middle age. So again we have gone congenital, middle age, elderly. Elderly in both cases was neck nodes. Middle age, carotid body tumor, what will be this? And congenital, branchial cyst was there, posterior triangle is what? Chalo, bolo. See, head and neck, very ignored topics, that's the problem. हम ध्यान ही नहीं देते इन चीज़ों पे, and they are actually such small, concise, precise topics. You should always score on them. Okay, the swelling here, this is probably a cervical rib. This is a cervical rib. That is why he is having thoracic outlet syndrome. This is a case of thoracic outlet syndrome. Syncope in upper limb exercise, thoracic outlet syndrome. It's called subclavian steal phenomena. The blood flow will go instead of the vertebral circulation will go into the subclavian circulation. Or he gets claudication in the upper limb when he exercises. So cervical rib, neck nodes, and yes, Pravesh, you're right. Congenital is going to be cystic hygroma. Cystic hygroma, no, not lipoma, cystic hygroma. These are the 3 common posterior triangle swelling that you need to know. So Allen's test होती है. Here what I do, I compress radial artery and ulnar artery alternatively. Okay, first I compress both, then I release one. Let's say I release the radial artery with the ulnar artery still being compressed, and then I see if my palm regains the color or not, or if it remains pale. If it remains pale while only the ulnar artery is compressed, it means that the radial artery is not going to supply the hand much. That means if the radial artery is not going to supply the hand much, ulnar artery को कुछ नहीं हो सकता. Ulnar artery is the dominant artery, and vice versa. That if I compress both and I release only the ulnar artery with the radial artery compressed, then I see does the palm regain color or not. If it regains color, that means ulnar artery is supplying well. Radial artery, okay. It is more beneficial to identify this before I am doing, yes, Datesh is right, ABG collection, arterial blood gas collection. Usme what I do, I puncture the radial artery. Now sometimes if I am very new, as you guys must have been new interns at some point of time, if I injure the radial artery and if it gets thrombosed, I should know that the ulnar artery is good enough to supply the rest of the hand. If the ulnar artery is not supplying the rest of the hand will become ischemic. So in that case, I should not play with the radial artery. I should let it be. That is the clinical application of Allen's test. Prior to arterial blood gas collection, to look for, here I am looking for role of ulnar artery. Is the ulnar artery going to suffice if the radial artery gets injured? Okay, that is the role of Allen's test. Be very clear on this. ये एम्स में पूछा है पहले. What test is this? What test am I doing here? I am palpating the radial artery and he is looking over here at the examiner. What test is this and what test is this? Palpating the radial artery and is looking away. No, not thrombophlebitis, Pravesh. Thrombophlebitis affects the veins. Phlebo means vein. Phlebitis is inflammation of the vein. So the first test is the Addison test. Addison test में what I do? All these tests are tests of thoracic outlet syndrome. Addison test, Halstead test, and Roos test. They are all thoracic outlet. Allen's I already told you. This is prior to AVG. In Addison test, what I do? Palpate the radial artery. Ask him to look to the towards the examiner. Turn to the affected side. Above one is Addison. Below one, this is not Addison. This is not right. I'll tell you what this is. So he looks towards the examiner. This is being palpated, radial artery, and he is supposed to take a deep breath. Now, when he takes a deep breath and looks towards the affected side, the pulse may become weak. That is Addison test. Turn head to affected side and inspire. Thoracic outlet becomes narrow. If he has thoracic outlet syndrome, the pulse will become weak. Halstead test is also called as the reverse Addison test. Reverse Addison. Isme what I do? I make him look to the opposite side. That's not the significant part. Palpate the radial artery and I compress his shoulder. Basically, either I compress them from here or I pull the arm down. Shoulder is going to be compressed. So the key part here is I'm narrowing the inlet, the outlet, by compressing the shoulder. That is Halstead test. Here he turns to the opposite side. The turning is not that important. Huh? It's not that important for him to look to the opposite side because that's not making a difference to the thoracic inlet, outlet. Okay. So these are the two tests, Addison and reverse Addison or Halstead. How you will identify from the picture. Picture देख के आपको ऐसे identify करना. Looking same side, Addison. Opposite side, reverse Addison or Halstead. Roos test की तो आपको there is no doubt in this. Roos is very easy. Means both the hands. So he is like this, shoulder abducted, elbow flexed, and he is opening and closing his fist. Okay, opening and closing his fist. He does this for 3 minutes. If there is a thoracic outlet syndrome, he will start getting claudication. Okay, for 3 minutes. Right? Yeah, Roos test. Roos, remember the 2O means you have to do it on both the sides. Bilaterality from the Roos. बाकी सारे टेस्ट एक एक साइड के. This is the only test where you are checking both the sides. Okay. Thoracic outlet syndrome, remember, most common cause is what you see in the X-ray. Cervical rib. Please understand, the rib need not be complete. It can be incomplete rib, partially bony, partially fibrous. Okay, it can be partially bony, partially fibrous. So you may not see the entire rib. On this side you can see it is completely bony. इसलिए पूरा दिख रहा है. Here only this much part is seen. मतलब ऐसा नहीं है कि आगे रिब नहीं है. आगे का part is fibrous. Fibrous is not going to be seen on X-ray. So most common cause of thoracic outlet syndrome, cervical rib. Then there are those types: fully bony, partially fibrous, and so on. What is the treatment of cervical rib? What is the first treatment of cervical rib? And what is the treatment of choice of cervical rib? Right test I don't want to discuss here because it's not that important. I want you to remember these 4 tests more importantly. ये 4 में से इमेज आएगी. Yeah. What is the first treatment of cervical rib? And what is the treatment of choice? First treatment, if the claudication is not that much, okay, if the claudication is not that much, the symptoms are not very severe, first treatment is going to be physiotherapy. If the person's quality of life is affected or his profession demands more mobility, in that case the treatment of choice is going to be extraperiosteal excision. Extraperiosteal excision of the rib. Okay, so what I am trying to emphasize is thoracic outlet syndrome, you don't have to do surgery always. हर बार सर्जरी करने की जरूरत नहीं है. Only if the situation demands, symptoms are too much, quality of life is compromised, conservative management is not working, only then you do the surgery. It's called extraperiosteal excision of the rib. Okay, so that's it for today. There were some more questions which we can do tomorrow. So tomorrow we meet again, same time, 6:30 p.m. Okay, continuing with our super specialty series. So tomorrow and day after we are going to have one class. Okay, and Saturday I'll keep some special class. I won't keep a YouTube class on Saturday. Okay, so we meet again tomorrow. Do remember to like this video. I hope you guys learned some new interesting things in head and neck surgery. It's a very big, vast system which is very ignored, which is why I felt we need to do this. Do follow me on Telegram. This is my link. If you want to have any doubts, you can always message me on Telegram. Okay, do like this video, and if you want to learn surgery comprehensively, this is my referral code 10 surgery. This will get you a 10% discount if you want to learn on the Plus platform. Okay, so thank you guys for joining me. See you tomorrow at the same time with more interesting clinical MCQs in super specialty. Okay, so take care guys, have a good day, see you.